Good afternoon, everyone. My name is Dr. Jody Guest. I'm an infectious disease epidemiologist and professor and vice chair in the Department of Epidemiology at Rollins School of Public Health here at Emory University. I lead Emory's COVID-19 outbreak response team and am the host of Emory's COVID videos, where we bring you new information about the pandemic. Today, I'm very pleased to be joined by Dr. Alex Trung. Dr. Trung is an assistant professor of medicine in the Division of Pulmonary, Allergy, Critical Care, and Sleep Medicine at Emory University. His research centers on long-term outcomes in survivors of critical illness, and he is the co-director of the Emory Executive Park Post-COVID Clinic. Welcome, Dr. Trung, and thank you so much for joining me today.
Thank you so much for having me.
Absolutely. You know, it's such an interesting topic, and I'm really excited for the things that we're going to talk about today. As we think about why this is so important, numbers of COVID-19 have passed 78.5 million cases in the United States, and there are increasing numbers of people impacted by long COVID, our topic here today. Despite more than 100,000 people getting COVID each day right now in the United States, most won't become severely ill and will fully recover, which is the great news. And the odds of illness severe enough to warrant hospitalization are dramatically lowered by becoming fully vaccinated. Again, another really good piece of information. But as I was preparing for our video today, I did pull out the numbers from the last time you and I spoke, Dr. Trung, which was September 30th of 2021, so less than 4 months ago. And in those 4 months, we've gone from 43 million cases of COVID-19 in the United States to 78.5 million cases of COVID-19 in the United States. That is 45% of our entire pandemic numbers in just less than the last 4 months. That is a lot of new cases and potentially a lot of new people who might be suffering and need your help, Dr. Trung. So I have read some estimates about, of all of those cases, how many might end up with longer term symptoms or long COVID. And I've read anywhere from 15 to 80%. So right now, where would you estimate that the numbers of people who are going to have some longer term symptoms actually might be?
That's a really hard question to answer, because I think we are lacking the data. That span of statistics that you referenced, being all over the board, includes patients who are severely sick in the hospital and those who are not severely sick. I think, unfortunately, we aren't at a place yet where we really know who's really at risk. And so we don't know what proportions are. If I had to guess, I would have to say it's probably closer to the 15 to 20% range, depending on the population you're looking at.
I think that's good that it's at the 15 to 20% range, but it's still a really significant issue for a lot of people. Kind of highlighting how significant that is, back in June of 2021, the AMA actually adopted a policy to support the development of an ICD-10 code to recognize post-acute sequelae of COVID as a distinct diagnosis. How important does this feel to have this recognition that this is a thing and that it is something that people are going to need care and support for?
I can't even express how important that really is. I think both from a medical point of view as well as a patient point of view. Speaking from a medical point of view, I think before we were having difficulties making sure that we're able to bill and appropriately scope the note that would actually warrant an insurance reimbursement. For the patient point of view, I think it's really important that we're recognizing that this is actually an entity. There's so many times patients would say that they felt unheard because people didn't believe that this was real. And I think them recognizing this as a disease process and assigning it an ICD-9 code is really important.
Being seen, feeling heard is incredibly important. We're going to try to talk through some of the whys for long COVID and recognizing that there's still so much to learn, but a lot has been learned in the last 4 months since you and I last spoke about this. Scientists and clinicians do seem to be making some progress on what causes long COVID, and a lot of it is breaking down into kind of 3 primary categories of how people might be getting this. So let's walk through these. I think the most obvious and the one we've been talking about the most is for long COVID associated with hospitalization. So in January alone of 2022, we had more than 150,000 people a day in the hospital for multiple weeks on end. Now we're closer to almost 80,000 people a day in the hospital. Is this a risk for all of them, or is this an ICU associated risk, or is it about the length of time you're in the hospital? How is this category of long COVID really coming into play?
I think this category is a little bit muddied for me, to be honest with you. I think that a lot happens in the hospital and in the ICU that puts patients at risk for long-term outcomes, regardless of whether they have COVID or not.
Mm.
Any critical illness would put you prone to having cognitive dysfunction, chronic fatigue, and chronic pain issues. We have a syndrome called post-ICU syndrome that actually captures this collection of conditions that patients suffer from. I think it's difficult to separate what is post-COVID syndrome versus what is post-ICU syndrome. There are some differences though. When patients come to me talking about their post-COVID symptoms, they do say very similar things, such as the nature of how the brain fog presents in terms of word finding difficulties, losing tracks of sentences, having difficulties concentrating. A lot of the cognitive decline that we see in patients who have post-ICU syndrome tend to center around memory loss. However, the post-COVID folks seem to present more in a attention deficit like syndrome. So I think there are definitely overlaps between the two. And I think as we move forward in this diagnosis, this first category of post-COVID folks will have to be better defined so that we can better separate it from the normal hospitalized post-ICU folks.
That's important to understand, that there can be a lot of overlap, and there's probably a fair amount of overlap in a lot of what we're going to talk about today. The next category is really the idea that COVID-19 can directly damage cells, and how long that might last and what kind of symptoms that might cause is a huge category of questions. So what are your thoughts on why this virus is directly damaging cells throughout the entire body?
I think initially we thought of COVID as a lung infection virus. And so that we do see a lot in our post-COVID populations, patients who have persistent lung inflammation, and some patients progress to scarring, representing that there is direct lung parenchyma damage. We're also realizing that possibly COVID is a vascular problem. It will affect the blood vessels, and in doing so can actually cause a whole cohort of symptoms that may be explained by decreased blood flow, such as some of the brain fog we're having, some of the cardiomyopathies that we may be having. I think that we're only at the very beginning steps of understanding that how it affects the brain. There are some data that suggest that there are pro-inflammatory changes within the brain and movements of pro-inflammatory cells past the blood-brain barrier that may affect the limbic system, or the kind of core systems of your brain that are responsible for things like mood, attention, memory. So I think that those parts are still coming through the research, and we're still in the process of trying to figure out what the importance of these different pathologies are. But I think the second category of post-COVID folks are going to be more interesting, because I think they point directly to things that we may be able to reverse, whether it's steroids for the inflammation in the lungs, or medications to help inflammation in the heart, such as slowing down the heart rate that happens in some of these folks.
I think that that's good news to hear you talk about, this is a group that you feel there are going to be some ways to help and to reverse those issues. The third category is frankly the most surprising as I read about it, because it was originally assumed that long COVID was very associated with severe symptoms when you have your original infection with COVID. But now there seems to be some data that people are developing new issues after fully recovering from COVID-19. Even people who didn't have symptoms can experience some of these kind of post-COVID related health issues, which can present as a lot of different types and combinations of health problems, and can seem to range for a long period of time, although certainly we don't have enough follow-up time to know how long this might last. What is going on with this third category of folks who seemingly recover and then have a new onset of health conditions?
I think of the three categories, that's probably the most frustrating category to figure out. I think that initially there was a lot of conversation as to whether inflammation was playing a role into why patients are having post-COVID syndrome. And the thought was the more severely sick you initially were, the more likely you are going to have post-COVID. That has totally been blown out of the water, and we do not see that signal whatsoever. We do get a population of patients who do have very mild symptoms. In some cases, they don't have any symptoms, and they just incidentally were found to have COVID, and then months later develop a syndrome of brain fog, fatigue, shortness of breath that isn't explained by some pathology in the lung. That may be related to some of the very preliminary research that we're seeing in the literature about autoimmunity, meaning that patients who get infected with COVID may recover from the initial illness easily, but subsequently develop some sort of autoantibody or autoprotein that the body does react to, and then manifests a lot of these other symptoms.
So important to consider all the different options. And Epstein-Barr is a virus that has getting a lot of attention, perhaps being associated with this. And even if you already have type 2 diabetes, do you think that these two things are also in play at putting people at increased risk for some of these longer term complications?
I think there's a high possibility that the Epstein-Barr virus reactivation may be playing a role. I think that research is still very new, and there's been some talk about recruiting patients, even from our clinic, to try to evaluate those studies. As for the diabetes component, that's the one that I have the most problem with. When I look at my population of patients, I don't see that signal. I don't see that most of these patients have diabetes. And then when I compare my patient populations and the rates of diabetes in that population versus my normal pulmonary clinic population, the rates of diabetes isn't that much different. So I would argue that I don't see diabetes as a big signal as to putting you at risk for post-COVID.
That's actually great news, because we already know that it puts you at risk for some complications from COVID. So it's great to not compound on that already complicated health condition to start with. How important is it to figure out if people have long COVID or if it's something else? What kind of tests do you do to make sure that it's not a thyroid condition or anemia or something else that might be going on, and it is truly something about COVID that they've had previously?
I think that's been the big challenge in our clinic. I think when patients come in with what sounds like post-COVID syndrome, the first step is always to make sure that there was a confirmed COVID test. A lot of patients may have symptoms that feel very similar to COVID and never got tested, and so thus in that population, we'll never know. When patients come in with these symptoms, specifically things like brain fog and fatigue, we do a whole slew of lab work that checks for thyroid levels, vitamin D deficiency, vitamin B12 deficiencies, anemia, and a bunch of other abnormalities that can be seen in the lab work. From what I've seen, I may have seen hypothyroidism once or twice in like the 300 patients I've taken care of. I think significant anemia is very rare. Any of these easily reversible causes are often not found. Patients often have things like vitamin D and B12 deficiency, but when you replete them, they don't feel much better. So I don't think that that's a cause. I think, unfortunately, and we're at the stage where if you have a COVID diagnosis and I can't figure out other causes for your symptoms, then I'm blaming it on post-COVID. I know that's not very sexy or scientific, but at this point in the evolution of this syndrome, this is where we're at.
Rule out diagnoses are not uncommon for a lot of different things. So I think that that's the position you're in, and think about the incredible progress you and everyone who's working on this has made in the last 2 years. So, so it's really incredible to see the work that you're doing in this clinic. And I'm curious, are you still as busy as you were when we spoke last in September?
I think right now I'm booked out to May. So I think, yes, we are very busy. Interestingly, I was expecting a much bigger wave of newer patients with the Omicron wave that just passed us. We're still getting a lot of patients that were infected August of last year, December of last year, just at the very beginning of wave. And of course, we're not testing whether or not these patients have the Delta variant or the Omicron variant. I think that we're still seeing patients who were of the previous waves right now. And I think as we get more attention for our clinic, more patients are finding us. Just yesterday, I saw a gentleman who's been suffering from his symptoms since March of 2020. So they are filtering through. We are still very, very busy. I am very, very hopeful because I think the numbers have gotten a lot better. And on top of it, I feel like we're so much better at taking care of patients. I think we have a little bit more data on our side. I think we have a lot more experience on our side. And I think we're able to approach patients in a way that's much more systematic than we were even back in September when we last talked.
That's great news. As you talk about people who are just now finding their way to you, some of these folks may have been suffering for a really long period of time. Are there communities that people who are suffering from these somewhat vague symptoms find online, and what's that support system like?
Yes, there's several communities, most of which is centered around Facebook groups that actually has been really helpful. And a bunch of my patients have found our clinic through other patients who've been part of that group. As for anything outside that off the Facebook, I don't know of any other groups. I'm pretty sure that Reddit and Twitter have groups that are centered around this, and patients are passing information around, both for the good and bad, mind you. But I think right now patients are finding the internet as a really good resource for finding information how to take care of themselves, as well as finding professionals who may be able to help them along their journey.
That support system can be so good if the information is accurate. When people come in to you, are they traditionally still suffering from the symptoms that you and I've talked about before, where it's mostly brain fog, fatigue, the things that you've already been mentioning? Or has any of that changed with the progression of the different variants from COVID-19?
I haven't seen much change, to be honest with you. A lot of our patients come in with very, very similar symptoms of the brain fog, fatigue, and shortness of breath. It's almost as if I can cut and paste one patient's story to the next patient. Very, very similar pathology. Symptoms, very similar ways that they've suffered.
And what about combinations? Are people coming in with one issue, or is it a kind of a host of issues that people tend to be coming in with?
It's always a host of issues. I think it's very rare that someone comes in with singular issues. Most of the time, patients are coming in complaining that their brain fog and fatigue are the biggest limiters of their activity of daily living, is their ability to get back to work, their ability to go back to school or take care of their kids. I think there's a smaller population of patients who have had chronic pain syndromes and chronic shortness of breath syndromes that are often very challenging to figure out.
And when is it that someone should seek care for symptoms that seem to be lingering from COVID-19, or even newly developing things after COVID-19?
I think that's a really important question. I think that what patients should expect is that after their acute illness, i.e. in the next 2 to 4 weeks after they've been infected, they're not going to feel well. They're going to feel like they have brain fog. They're going to probably have fevers and chills, body aches, and just the fatigue. Now, if those symptoms last beyond 4 to 6 weeks from their initial infection, and it's affecting their lives in the ways that they can't do their job, or they're affecting how they're functioning in the daily activities of daily living, then I think that's when it's really important for them to come see us. There is a population of patients who do have lingering symptoms past that 4 to 6 weeks of infection, and it's just getting better on its own, but slowly. Maybe those patients can wait to see us because, to be honest, it takes so long to get into our clinic that they might have already improved by then. Those patients, I would say, wait and watch. But if it's really affecting you and it's not improving at all, then come to see us, and please don't wait for too long to come see us.
Is there a definition for long COVID? Does it start, if you still have symptoms at 3 months, or is it a shorter period of time? Is there any sort of timing in this definition yet?
So from last I've seen, it's 4 to 6 weeks past initial infection with symptoms that are affecting the activity of daily living.
Okay. So it actually is getting shorter, because I think at one point in time it was if you have symptoms persisting past 3 months. So that's tightening up a bit. Let's talk for a moment about children. There was originally a scarcity of data about if this could affect children. And so there was the thought that it actually may not be any complications for kids to have persistent or long-term complications or these more vague symptoms after COVID-19. Are children now able to get it, or do we now know that they can get it? And do they have the same type of symptoms and same duration of symptoms that we see in adults?
I think it's more clear that children can definitely get the long haul of post-COVID syndrome. I think they tend to have less likely symptoms of shortness of breath and respiratory issues, more likely to have a lot of the brain fog and fatigue issues that we're seeing. Obviously, in my clinic, I see adults, so everybody has to be over 18. But I do get a lot of emails about 14-year-olds and 16-year-olds and 17-year-olds who need help and who've had symptoms for over a year and they can't get back to school and do the things that they need to do. Most of which, again, centers around the brain fog and fatigue.
That's so hard to hear. You know, another demographic that seems really different is it appears that the data are that women are suffering from long COVID more than men. Do you have an explanation for that, or is that at this point in time still kind of anecdotal information that we have without an explanation?
I think the data we have is that more women are showing up to clinic than men are, i.e. more women are seeking care for post-COVID syndrome than men are. I have no idea whether that's because post-COVID syndrome is affecting women more than men, or is it that they're just seeking care and men are just being stubborn and not seeking care? I will say that in my clinic, it's about 2 to 1 women to men. And I more likely have follow-up with my women patient than my male patients. So I think in part it has to do with a selection bias, but I wouldn't be surprised if the rates are truly a little bit higher in women than men. In similar syndromes that we've seen, such as chronic fatigue syndrome, we do see that those rates are slightly higher in women than men. So post-COVID is thought to be a similar path to that. And so I wouldn't be surprised if the numbers do play out.
I think you're probably right there, that there's a little bit of bias involved in getting into care, but I think it's very interesting to see that we might have some sex differences between these symptoms. Let's turn to vaccination for the last thing we talk about. We know vaccinations have kept people much safer and significantly decreased the risk of severe COVID-19 and death throughout this entire pandemic since we've had vaccinations available. Among vaccinated people with breakthrough infection, are there vaccinations protecting them from any of these longer term symptoms of COVID-19?
The data we have so far is suggesting that yes, indeed, it is helping protect you from having post-COVID syndrome if you get a breakthrough infection after you've had all 3 of your shots, which includes the booster. I do have a small population of patients who've had post-COVID syndrome after they've been vaccinated, but it seems like those folks tend to have rather mild disease, and those tend to resolve a lot faster than my folks who have not been vaccinated and got COVID, and thus post-COVID syndrome after.
So some more good information and some more good data to support how important vaccinations are and how much they'll protect you from all the parts of COVID-19.
For sure.
So Dr. Truong, I just want to thank you again. You know, I know scientists are starting to get insights into this lingering disorder that affects some people who have had COVID-19. The work you've done and the clinic that you helped start at Emory is incredibly important, both from treating people, but also just acknowledging that this is something that people are suffering from, and it's not something that is just in their head. For those of you watching, the safest way to keep from getting long COVID or post-COVID syndrome is certainly to make sure you keep from getting COVID-19. And the best way to do that is by getting vaccinated, getting a booster. Make sure you protect those people who are around you. And when cases are still high out in the community, please wear a mask when you're indoors in public spaces. Dr. Truong, thank you again for everything that you're doing for people who are suffering from this syndrome and the information you shared with us today.
Thank you so much for having me. I appreciate it.
Absolutely. Stay safe, everyone, and thank you so much for watching.